Sir, for inviting me here for this important topic of counting calories versus counting the hours. I was trying to understand what to speak in this topic, and in 13 minutes it's like a TED talk for me. But overall, you see the diabetes and obesity is increasing like anything, and people are resorting to all sorts of things, anti-inflammatory diets, medications, but none of them seems to be still helping. And we know that it is very difficult to restrict to calories for longer period of time. But time-restricted eating has become a very important, denominator in terms of adherence, and people are getting benefits. So let's look into these two aspects of what is important, counting the calories or counting the hours, out of the both. So I'll be talking about mainly the science of the calorie restricted eating and time restricted eating both, and also we'll talk about the implications of each. Then I'll be talking something about the controversies around the time restricted eating and some important messages for you to take home. 3 important slides at the end. Please watch out for those important slides. You can use it in your clinical practice. So this is a birth of calorie restriction coming from Mr. Clive McKay. He was a pioneer of the experiments which have been done. Gold standard experiment till date now for calorie restriction. Made an important bread called cornmeal bread with protein and vitamin, fed to the rats for and for a certain period of time, and showed that they live longer. And still now, this was used in World War II for the rationing of the food, because food was not there. So they used this kind of a product for the soldiers, and they saw that obesity and diabetes went down clearly in those patients after some time. Now, if you see this, the Clive McKay was honored. This animation is not working, but this is a Elsevier Nutrition Journal, and they honored these experiments after 75 years. So 90 years of research, and still holds the test of time. These are the original research which he has done, the history of the nutrition research by Dr. Clive McKay. And time restricted eating has a roots in the religion. Hindus do upwas, there is a Ramadan, there is a Paryushan. So there has been their law for a long time, but it's not for the health benefit, it's for the spiritual benefit and deep-rooted in behavior, discipline. But now it has found a kind of a way into the science and physiology, and this is a man, Joseph Takahashi. He has done a lot of seminal work on discovering the circadian gene, clock genes, and he said that if you actually go according to these genes, because the metabolic machinery is actually governed by these clock genes, and if you actually do a time restricted eating, you can improve the insulin sensitivity and blood pressure. So this is how he has given this kind of a concept, and based on that, Satchidanand Panda from the Salk University has said, he had done a rodent experiment, and he has said that if you feed the rodents in the night only, and not give them in the daytime, they do more better than the rats who are fed in the day. So this is how it has been going on for a long period of time. Calorie restriction means 20 to 30% restriction of calories, and you can do it by limiting the portions or calorie tracking or micro targets, but it requires sustained discipline and monitoring, and actually it's a gold standard till now for obesity and longevity trials. Time restricted eating means there's no counting of calories, but you have to define a window of eating, 6 to 10 hours of typical window of eating, and fasting for 14 to 16 hours. So you have a kind of a pattern which you can use, 14 to 10, 16 to 8, or 12 to 12, and it aligns with your circadian rhythm. And this is mainly very important because it changes your behavior. That's a very sweet spot of this, that it changes your behavior. The key difference is calorie restriction means how much, time restriction is when you're supposed to eat. There is a tracking required in calorie restriction, but you don't have to do any calorie restriction or tracking in TRE. Is very simple to use. It's flexible to eat in calorie restriction. You can eat any time of the day, but the same calories. But TRE gives you a rhythm. You have to follow that kind of a disciplined lifestyle. Evidence is much more wider for calorie restriction than TRE, but we are getting into it. 10 to 15 years of research, both have shown to have a benefit in terms of cardiometabolic risk factors. So this is a very good comment from Kelly A. Vaughan in this cell metabolism paper. Watch the clock, not the scale, because scale is not everything. It can give you a good benefits only if you watch the clock. By changing your circadian rhythm, body composition, microbiome, triglycerides, everything will come down. Even if you don't lose weight, energy balance is very important, and calorie restriction seems to restore this energy balance by reducing the fat mass and visceral adiposity, and improves the insulin sensitivity and hyperglycemia. But the point here is, when you start eating less and less, the resting energy expenditure reduces. That is called adaptive thermogenesis. And because of this, there's a modulation of hormones like ghrelin. The people want to eat more, and that's the reason they can gain weight again. But this is a caution which you have to see there, that people will start gaining weight and they start feeling hungry. But it improves your blood pressure, LDL, and inflammation. There's a lot of molecular pathways to explain the calorie restriction. With just a simple explanation that if you use this calorie restriction, you are going to have a better clearance of debris, autophagy. Energy efficiency will improve, mitochondria will improve, mitochondrial switching will improve, metabolic switch will become better. There's an increased mitochondrial biogenesis, and that explains your health expansion in the models. That's a very important part. It follows that calorie restriction is known to increase the longevity because of increased mitochondria. But total energy restriction, people are still confused. What is it? One is a classical calorie restriction. There are other types of calorie restriction like intermittent energy restriction, where you do 2 days of fasting, 5 days you can eat as you wish, or you can do alternate day fasting. That is another way of doing it. So there are a lot of evidences to compare. 5:2 seems to be better. I will come to the evidences later. Circadian rhythm is restored by time restricted eating, because if you see the glucose tolerance is much higher in the morning, and in the night is lesser and lesser. So people who are eating in the night, like shift workers. What is a shift worker? Who is awake from 10 to 5 p.m., 2 to 3 hours in that period of time. For 50 days of year, that is called shift worker, and most of our sitting here may qualify for shift workers if you are doing that. So those people tend to get obesity and diabetes. So restricting those, changing the time of eating can realign the circadian rhythm and can reduce the glycemia. If you look at the fasting, when you do a fasting, what is happening? You're trying to improve your metabolic switch by changing your fuel from glucose to ketones, and you improve the beta oxidation of fatty acids. So this reason for getting diabetes, one of the seminal reasons is mitochondria cannot do metabolic switch, cannot use the ketone bodies, because you always laden with glucose, and that's when this switching doesn't occur, patient develop diabetes. This can be restored by doing fasting. You can do both approaches, hybrid approach, calorie restriction and time restricted eating, and that has led to show beautiful better outcomes in terms of energy, insulin sensitivity, blood pressure improvement, type 2 diabetes improvement, mast cell improvement, and it is promising for the real world sustainability. It holds a good promise. So both can be used, both can be exploited. And if you see the molecular pathways, here you have a clock genes coming into picture. The BMAL one is a night clock gene, PRCRY is a day clock genes. They tend to retain your rhythm of eating and feeding, and it, because of this, which has been disrupted, late eating here. If you are doing a late eating, this is getting disrupted. If you start eating in a time, this clock genes start to work better, and they will improve NADs. And SIRT1 is a longevity gene, will improve the mitochondrial function. Again, coming to mitochondria, gene expression of metabolic genes will improve, and they will reduce the obesity and diabetes in individuals. Gut microbiome, who we just spoke about, also is affected by change in the circadian rhythm and time restricted eating. So you can clearly see all these things are improving. The diversity, the FB ratio, the gut barrier integrity is also improving. Your short chain fatty acids, butyrates, which improve the insulin sensitivity and inflammation, they are also increasing. So that's a very important part to say this. There's not only the genes are improving, the mitochondria is improving, the gut microbiome also is becoming healthier and healthier. So if you see, metabolic syndrome and diabetes have actually rooted into insulin resistance, and insulin resistance disrupts all these rhythms, circadian rhythms, and it also reduces this fuel partitioning, very important. Impaired fat oxidation in obesity and diabetes, which is restored by this, and that's why we need clinical trials to see whether this really works in these two pathophysiologies. So what you see is calorie trial, very important landmark trial done over 2 years. 25% of calorie was restricted and showed reduced insulin resistance and LDL, and it also showed improved markers of inflammation and oxidative stress. And if you see this observation coming from the Okinawa and similar population, blue zones which are called, they show calorie restriction causes longevity. Diabetes prevention trial, modest calorie restriction with some activity reduce the diabetes incidence by 58%. That also is one of the indirect marker or indirect trial to say that calorie restriction works. So still is a gold standard for dietary intervention. The time energy restriction, there are another clinical trials where you can see the tempo diet trial and Matador trial. If you restrict the energy, moderate restriction versus severe restriction, You can get a good weight loss, you can do fat loss, but also you should be aware of bone loss and muscle loss in this patient. So that is very important point which came out of this trial. Meta study is when you keep doing energy restriction, patient will hit the plateau and will not be able to lose weight. So what you do, give her 2 weeks of energies, normal energy blocks. Give 2 weeks of normal energy diet and they'll be able to break the plateau. That's what Metadose study tells you the adaptive thermogenesis, which is coming because of continuous energy restriction, is broken. Then you have another lot of other studies to show the similar kind of results. If you see that time restricted eating, similar, many studies are there, and if you see them, especially the Satchar and Panna studies and other studies, they have clearly shown that very important reducing the inflammation, insulin sensitivity, and also you can see that it is very important in hepatic steatosis. Fatty liver disease, time restricted eating works very well, and the trials ongoing on looking at diabetes, obesity and cardiovascular risk. So weight loss outcomes have been almost similar in both, almost 5 to 10% weight loss in 3 to 6 months, and hybrid approaches is showing good results. If you combine both, you get the better results. Cardiometabolic outcomes, if you see, are also good, as well as but you see the meta-analysis of all the trials. And if you compare all this calorie restriction versus fasting 5:2 versus total energy restriction, what works best? 5:2 works best, followed by alternative fasting, followed by calorie restriction, and then TRE. So this is the meta-analysis which is shown. Now there is another trial which is been conducted in 2025. There was a study by Bravo Garcia and Krishnavar, and he said that if you combine both total energy restriction and this one calorie restriction, you have optimal body composition, and also you have a good metabolic parameter control. So this is very important. This is a new controversy which came now, cardiovascular risk with TRE. These were 20,000 patients followed for several years, and they showed if you reduce the eating window for less than 8 hours, you might hit a CV mortality, especially the people who had a high CV risk. However, there are some tweaks to it. It's an observational study, and the sample size in those category was very small. So they remember, and they were only obese. Their BMI was much higher than other people. So they were more prone for cardiovascular disease. So we interpret with a caution this study, but you should always personalize when you are giving that advice to people who have cardiovascular disease about the time restricted eating. This is the gist of all the trials, and about TRE and 5:2 and everything in terms of weight loss, A1C reduction and fat loss. Adherence is very good with TRE, sustainability also is good. So calorie restriction may become a little difficult in the long run. So it is very important to understand patient's personality, lifestyle, and accordingly prescribe. What are risk, pitfalls and contraindications? The risks are lean mass muscle loss, micronutrient deficiency, and you can end up with adaptive thermogenesis leading to weight regain, mood fatigue in some. Fatigue can also become very important. And TRE risks are hypoglycemia, if your patients are insulin and sulfonylurea, late night overeating, GI symptoms, sleep disruption if window poorly timed. So if you're not timing the window poorly, you can have a problem with sleep. Contraindications are pregnancy, lactation, eating disorders, severe illness, children, adults, and do not use this. Women eat one specific diet which has come now, 1 meal a day. Eat for 2 hours, and 22 hours or 23 hours you should not eat anything. That's a very disruptive kind of a diet. People, a lot of people are following it, but do not advise to any person because can lead to a lot of problems. Older adults prioritize protein intake and resistance training, very important to preserve sarcopenia. Medical adjustments are adjust your medications because patients on sulfonylurea insulin can end up in a problem. So when you're prescribing those diets, adjust the medication and use CGM for the safety net. Monitoring baseline 8 to 12 weeks weight, waist, BP, lipids, A1C, and adjust the protocol to data. Matching phenotype to strategy. The last few slides now. Night eaters, shift workers prefer early TRE from 8 to 4 p.m. When you are eating, you should eat between 8 and 4 p.m. to restore the circadian rhythm. High structure personality athletes, they should have macro targets, and optionally, what is this? Optionally placed within the 10-hour window period. Plateau prone diet, as if somebody is prone to plateaus, then you should consider Metadose style. Give 2 weeks of energy restriction, 2 week normal energy, and you will see able to break the plateau. Type 2 diabetes on insulin or sulfonylureas, start with mild TRE, 12 to 14 hours window and calorie guidance, and titrate cautiously. Use CGM in this patient compulsorily. Adults who are sarcopenic, use 1.2 to 1.6 gram per kg protein. Beyond this, no benefit, and use resistance training. NFLD, MSLD, use early TRE. Early TRE means you should, for last meal should be at 4 or 5 o'clock in the evening. Benefits are more. Behavioral preference wins always. Behavioral preference wins because patient, best diet patient is on adhering to certain kind of diet for longer duration of time. That is the best diet which you can give to the patients. Last slide, energy deficit drives weight loss. Timing helps adherence and circadian physiology. Time restricted eating, any pattern you take, is an effective as a calorie restriction. When it reduces calories, not superior when calories are matched. Matador style you can use in your clinical practice to break the plateaus. Hybrid is very important. The calorie restriction, time restricted eating, both can be combined with protein with resistance training. Best combination you can give to the patient, and mesh the method to phenotype of the patient. CV risk is very important, so keep in mind when you are prescribing to the patients of cardiovascular problems, monitor, iterate, and personalize the diet. That is very, very important. And use your data, weight, waist, blood pressure, A1C, lipid profile to refine your prescription. Thank you so much for your patient listening.
Thank you so much, sir. That was a wonderful presentation on